Welcome to Gutsy Talks. I'm Rachel Larson, your host, naturopath and nutritionist, and I'm here to have real, honest conversations that can help you heal your gut, calm your mind, and fall back in love with food. Together with leading health experts, we'll dive into all things gut health and explore the deep connections between your gut and overall well-being, so you can feel empowered to take control of your health and live your best life. If you love all things gut health, follow me for more on Instagram at rachel.larson or head to rachellarson.com.au. Now, let's get into today's episode. Today I'm joined by Rhiannon Hardingham, a highly experienced degree qualified naturopath, nutritionist and practitioner educator with more than 20 years of clinical practice. Rhiannon's mission is clear: to transform the way both patients and practitioners understand reproductive and hormonal health. She's passionate about empowering patients to take charge of their health and educating clinicians so they can confidently support more people with complex conditions. And this episode is all about PCOS, polycystic ovarian syndrome, a condition that's often confusing, frequently misdiagnosed or undiagnosed, and leaves so many feeling stuck on the pill with no clear answers. If you've ever wondered why your symptoms don't add up, or if you're looking for evidence-based practical strategies for PCOS, you're in the right place. Welcome, Rhiannon. Thank you so much for being here today.
Thanks for having me, Rachel. Very excited to be here.
I'm super stoked for you to be here. If people haven't heard of you, this is an absolute gift to them. You really are a leader in the field of all things reproductive and hormonal health. You're a total trailblazer for so many practitioners. And I know, like you were saying before, you've had a really busy morning in clinic. So you're getting a lot of the tricky cases as well, because you're so incredible at what you do. So to have you here to be talking about PCOS today, very blessed and very grateful.
Oh, thank you. That is a very kind introduction. I'm very
It's
grateful.
it's all true. So, I mean, let's talk about PCOS. And
Mhm.
it's funny because I was telling my partner yesterday, I'm like, oh, I've got Rhiannon on, we're talking about PCOS. I didn't expect a 36-year-old male to know too much about PCOS, but it was just
Mhm.
really interesting that how much he didn't know, and I
Mhm.
mean, it's not just males, it's females as well that we're trying to understand this, what sounds like a really, PCOS, all right, polycystic ovaries, but we're going to find out today that it's so much more than that. And I
Yeah.
guess the ins and outs of why misdiagnosis has been such a problem. So I guess to
Yeah.
start with the basics, what exactly is PCOS? And how do you, I guess, explain it to patients beyond just what that label is, I guess, suggesting it
Mm.
is?
Yeah, well, I think to really illustrate that point, there's a lot of discussion going on at the moment, and there's really an inevitable change of name
Good.
coming up.
Great.
Because the name itself is very misleading. We technically, and I don't really go by these because they're not that useful from a functional medicine perspective. But technically, medically, there are the four phenotypes that are discussed, and one of them doesn't even require polycystic ovaries to be present for part of that
Great.
diagnosis. So polycystic ovaries may or may not be part of the presentation. And then the other key considerations are hyperandrogenism. So as we know, high androgens, predominantly testosterone being the famous one, but it can also be DHEAs or androstenedione, or more difficult to detect, DHT.
Hmm.
And that, of course, can lead to some of the really common symptoms such as acne and hair growth on the body and hair loss on the head,
Mm.
androgenic alopecia, as we call it.
Yep.
And then, of course, there are the metabolic symptoms. So, both on paper, insulin resistance, hyperglycemia, and of course, clinically, that presents as weight gain, especially with a tendency to that weight gain around the middle.
So it sounds like it's very much like a hormonal and metabolic driven issue.
Yeah,
And it's
yeah.
not, and like you said, like it's actually the presence or absence of the ovaries being polycystic is kind of not always even part of the issue, So
Yeah,
I think a name change is clearly appropriate. It'll be
it
exciting. Do
is.
they have any kind of, is there any kind of front runners as to what that is?
So metabolic reproductive syndrome, persistent ovulatory dysfunction syndrome, ovarian dysmetabolic syndrome. That's from a 2024 paper that was actually based on a review or an interview style, if you like, of Australian GPs. Who agreed, 74% agreed that the name was confusing and needed to be changed.
Yep.
But there has been a little bit more discussion about it in the media recently, and it's possible that I've missed something and they've landed on one, but it's very imminent. Like, it's really happening. It will happen in the next year or two.
Cool.
And the other component I should mention that is a feature of PCOS, of course, is the oligomenorrhea or amenorrhea, the irregular or absent menstrual cycles. And that, of course, heavily goes on to impact fertility, and infertility is unfortunately a significant characteristic for a lot of patients, especially those that we end up seeing in our practice.
So you mentioned that, like, the subtypes, which people are using maybe that type of language just to try to understand it better, but you're finding in clinic that you're not needing to know the subtype. So is it because, like, there's a bit of an interaction between them, or you're like, why is it that those quote unquote subtypes, like, talk about that a bit more?
They are a really positive adoption from a conventional perspective, because it gives diagnosing clinicians an opportunity to diagnose those who don't tick all of those boxes. So there's still diagnostic capacity if, for example, somebody has insulin resistance and hyperandrogenism but doesn't have irregular cycles. Whereas previously it was more specific in that all of the boxes really had to be ticked. So these 4 phenotypes have allowed that more inclusive consideration from a conventional perspective. But from my perspective, and as a functional medicine practitioner, both clinically and as an educator of other practitioners, for me, it's 100% about what that person is presenting with. And medically, of course, and no shade at all, but medically, there's not as much of a need for individualization, because interventions are a bit more straightforward, uniform, protocol driven. So once you get the phenotype, you just treat based on that phenotype. Whereas I want to know exactly what your hormones are doing, not just your androgens, all of your hormones. From that, we can elucidate what your likely ovarian function is. We look at things such as aromatase, for example, which is the conversion of testosterone to estrogen in the ovaries. We can look at genetic contributors to that, so what we call SNPs, that affect how an individual processes those hormones. We, of course, look at our gonadotrophin expression, which has nothing to do with the phenotypes, but actually functionally is significantly impactful on how both the condition presents itself in the individual and how we would treat it. And of course, gonadotrophins are the hormones that the pituitary and the brain produces that tell the ovaries how to produce hormones. So we look at those, and there's a really interesting body of research now that shows that those gonadotrophins, those brain hormones, are directly influenced by stress, by neuroinflammation, which of course is impacted by systemic inflammation, and can also, of course, be influenced by insulin resistance and calorific intake. But knowing why for that individual that's happening allows us to really accurately address what's going on for that individual, rather than just say, you have this, you're going to go on the pill, and then when you want to conceive, we'll give you Clomid. And of course, the guideline is always to lose weight. How useful that information is when it's given without a lot of support, maybe other than some metformin, is questionable. So obviously, being very holistic, we're much more interested in what's happening for that individual and how we can change that for them, rather than just putting a label on them.
And I think that's just one of the key differences between, I guess, those lines of thinking in terms of how we're
Yeah,
approaching health. There's more that individualistic, holistic, explorative kind of making sure all things are considered rather than just, okay, you've ticked that box, you're in that category, that's just what we're treating. And again, no shade, but we're just pointing out differences, people. Like they're
exactly,
there.
exactly. Room for everyone. We work very
Yeah.
collaboratively, not only with GPs, but also with fertility specialists and
Yeah.
obstetricians. But a lot of GPs also do our training
Yeah.
and adopt some of those strategies too. So when we can all work well together, it's
It's
the best thing for
beautiful.
the patient, and that's all that matters.
Absolutely. I'm so
Mm,
for team care support. That's, yeah,
yeah,
it's always so good. So I guess like
absolutely.
if, those key symptoms of PCOS, you've kind of labeled a few. So can we just like make them really clear as to why someone may suspect? Again,
Mm.
like I think this maybe misdiagnosis or underdiagnosis can go on. So if someone's like, I still have these symptoms, I think I am a candidate for PCOS. What are we looking for?
So certainly the key things that will express themselves in adolescence and puberty,
Mm,
which is when it will come about for most people, because really just to uh, emphasize a really important factor with PCOS, you do really need to be genetically predisposed to it.
hmm.
Every woman and person with ovaries who puts on weight doesn't go on, of course, to develop polycystic ovarian syndrome. And
Yeah.
everyone with polycystic ovarian syndrome genetic tendencies doesn't go on to put on weight.
Yes.
But it is having that perfect storm, if you like, of nature and nurture,
Yeah.
but it will often express itself in one way or another in the teenage years, whether that is a regular menstrual cycle, so difficulty establishing regular cycles, of course, a significant tendency to acne, or a significant tendency to easy weight gain with puberty because of the insulin resistance that comes with the hormone picture for those for whom that's their version of it,
Mm,
which can, of course, be very challenging from many perspectives, and does unfortunately lead to a higher incidence of eating disorders in this cohort. If you
yes.
learn if you're fearful of this early, of course, you're much more likely to struggle with your relationship with food,
Mm,
especially if you're not informed around what's going on and how you can best manage it.
yeah.
So
That,
it is those symptoms early on, and then later, it might be those things actually becoming apparent because there's this challenge with conception, or because someone goes on the pill as a teenager because of those symptoms, and then they come off and they don't get a period afterwards, or their periods are irregular, or their skin comes back when they come off the pill, etc. So
mm.
they're the key things that will lead someone to seeking out a diagnosis.
And like that, it's such a brutal time as a teenager, as if life isn't hard enough
Mm,
at that time anyway. And then
yeah,
you've got these issues, which nobody wants at that. Acne and weight gain as a teenager is horrific for your mental health. And then, of
yeah,
course, there's all that, there's so much online kind of advice,
yeah,
good or bad or terrible that they're
yeah,
accessing. Like it's a really, yeah, I can understand that really slippery slope of how people find themselves in positions that they're just like, oh my God, how did I get here? You mentioned
yeah.
something really interesting about the pill. And I
Mhm.
guess like, can you please speak to that? Because I think people like the pill caused my PCOS or,
Yeah,
those type of, I guess, statements, and
yeah,
thoughts in society. Can you speak to that a little bit more?
yeah. So the pill certainly does not cause PCOS, but it may mask the
Mm,
symptoms. Obviously, it will mask the symptoms for you regarding um, uh, irregular cycles, and potentially the often, of course, the acne and hair growth cycles. Whilst you may become otherwise prone to it underneath
yeah.
that, with the individual driving factors like stress or insulin resistance or even chronic inflammation,
Mm,
all independent drivers of the hormonal presentation.
Mm.
So when then it's been masked and you've come off the pill, it may feel very obvious
Yes.
that you have, it may feel that you've suddenly developed this condition, but that's,
Yeah.
you've had a genetic tendency for it, for
Yeah.
sure.
So it's more that masking, which I think is
Yeah.
important. And maybe like that for some people is the slap in the face, or like there is something up with my hormones, but it's just again been masked for months or years, however long it's
Yeah.
been.
And
Yeah.
I see so many people, as I'm sure that you do, but over the years, so many patients who have been on the pill since they were 14, 15,
Mm,
and their cycles were irregular because of PCOS, and they haven't come off it until they want to conceive in their early
yeah.
30s or even later. And of course, the symptoms are going to really come to a head at that point.
Yeah, absolutely. And yeah, that shifting from, not wanting to conceive and managing symptoms to then going the other way and then finding out there's a PCOS situation there. Like,
Yeah,
yeah, that's a lot for people to then kind of mentally compute. They're like, shivers, I
it is.
can't conceive, or at least I'm not getting my period back, which was, pretty handy when you're trying to conceive. So that
Yeah,
kind of makes sense. And you do hear of that situation frequently. So
yeah.
like when we're talking about people wanting to understand the root cause of their PCOS, you've mentioned a few things. So you've mentioned genetics, the idea of that nature and nurture. You've mentioned
Mm.
stress, inflammation. So like what are
Mhm.
those like real key root causes, those real big themes that we're looking at in a PCOS patient?
Certainly the most primary consideration is the metabolic component, so insulin resistance.
Hmm.
In very crude terms, the cohorts are often broken up in the literature into those with higher and lower BMIs,
Hmm.
because you don't have to have a higher BMI to have PCOS at all.
Yep.
You certainly can have a BMI under 20 and still have PCOS.
Yeah.
But even then, there is often a tendency to what we call hyperinsulinemia. So higher resting insulin and higher insulin levels in response to food than we would usually expect to see
Hmm.
with that particular body type, if you like, or weight. And again, maybe that tendency to easier weight gain, although that doesn't always have to be
Yes.
there.
Yep.
But that is a really key consideration, because for those with that PCOS presentation, very small changes in blood glucose regulation can cause hormonal irregulation and ovulatory issues. And that can be just a result of very poor carbohydrate tolerance. So I'll often tell my patients, it's I'm very sorry,
Yeah.
but for you, you can thank your parents because it's genetic, you just have very poor carbohydrate tolerance
Mm.
compared to the person next to you.
Yep.
And so for you, we certainly don't want to cut out carbs. It's important not to cut out whole food groups, but
Mm.
we need to look at ways in which we can incorporate carbohydrates into your diet that don't drive this hyperinsulinemia, and look at things that we can use to positively influence your insulin sensitivity. A really obvious example of that is resistance training.
Yep.
Muscles are far more sensitive to insulin than fat cells or any other cells. So the more muscles we have, the more
Yep.
sensitive we are to our insulin levels, and the better we regulate our glucose. But the other thing in particular about the insulin resistance with PCOS is that the PCO ovary
Yep.
is far more insulin resistant than the periphery.
Mm.
So even when we see very minimal level changes on paper, and certainly those that fall well within normal
Yep.
conventionally, we can elucidate in those with clearly ovarian issues
Mm.
regarding normal hormone production, that there's higher insulin resistance going on at the ovary. So we will use certain strategies around that, dietary and lifestyle for sure, but also specific supplements like myo-inositol
Yep.
is a well-known one that we will use to help to improve that insulin sensitivity, functionality, and inflammation
Mm.
resistance at the ovary, to make it less sensitive to that to that hyperinsulinemia.
And I think that is like so important, just that concept of, you as an individual, there's this difference in how your body is metabolizing glucose and insulin and how it's,
Yeah.
how receptive and how sensitive it is to it. And
Mm.
that, foods that would otherwise be fine for someone is going to have a bit more of a drastic impact on you. And
Yeah.
even what you said, and we'll get into testing and how we do that, but even this idea of looking at like an insulin test and you being within that normal range and that still being high enough for you. I think this is where it just kind of shows that like small changes but big impact in the individual, and that
Yeah.
sometimes these readings and levels, it needs to be kind of seen with the individual, not just seen on the paper.
Yeah.
Like I think
Yeah.
that's just such an important thing because I'm sure people are like, I'm eating whole carbohydrates. I'm not eating any, X, Y, Z, and yet I've still got insulin resistance. But this is why this is what
Yeah.
you're explaining.
Exactly.
So
Yeah.
frustrating, but like important
Yeah.
to know.
Yeah, and we all do have our weaknesses that we've inherited from our parents. The good thing, of course, is if you know what they are and you have the tools to
Yeah,
address them, then you can mitigate the short and long term, importantly, long term
yeah,
consequences.
yeah.
Whereas if you're not informed, then you just don't have the knowledge or power to do anything about it.
And I think that goes for any condition
Yeah, it does.
that like once you understand what you're, I mean, we're human, like none of us are perfect. We're going to have our little Achilles heels that we need to
Hmm.
kind of nurture. And that's why
Hmm.
that whole idea of individual medicine, individualization in what you're doing, diet, exercise, all those things, that's kind of why it's needed, is because we've all got our stuff that we're managing.
Yep.
Now, this is obviously like I love the gut. The gut is my place that I'm my happy place. But
Hmm.
is there a link between our digestive health, our gut, our microbiome, and PCOS or any conditions that you often see, associated with that? Like talk about the gut PCOS connection.
Yeah, it's really interesting because, certainly as naturopaths, we've been sus on the gut forever. I mean, I always joke about how, 20, 25 years ago at uni, when we were taught about the microbiome's influence on everything, we were taught about it with no doubt that it was 100% fact and that it was the root concern with everything. That was well before we had any quality gut testing and well before we had any thorough studies. But now we've been proven to be well and truly right. And we have both those tests and studies available to us to confirm that.
Yeah.
Specifically with PCOS, of course, there can be a huge variety, as you know very well. Anyone with any condition can present with any sort of gut irregularity or microbiome dysbiosis that should be treated individually. And we do a lot of testing, as I'm sure that you do, to treat the individual. But some trends that have been found
Mm.
in the research, Prevotella copri dominant guts have been found to be consistent, not with all obviously, but with many metabolic PCOS cases.
Yep.
As we know otherwise with Prevotella copri, it is associated generally with a higher risk of obesity and metabolic disease. And a really interesting thing about it, I think, is that it can be a bacterial species that can go the other way, and it responds very well to a non-Western style high fiber
Mm.
diet. But if you put a Prevotella copri gut in a Western style diet environment with very little fiber and a lot of processed foods, high fat and high protein, then it becomes very pro-inflammatory and very metabolically problematic.
Yeah.
So, obviously we have our little tricks with our pre and probiotics and our herbs and polyphenols that we'll use supplementally to help to optimize the gut, but it has to include diet. And that's of course something that anyone can do, is look at diversifying their fibers, looking for a minimum. I'm sure you have a recommendation that you usually say, but I'd say minimum of 25 grams of fiber a day, ideally above that.
Yep.
And making sure that you're getting a variety of those fibers. I mean, we spoke about my busy morning today already in clinic, but that's something that I've already spoken about 3 or 4 times today, giving lists of varieties of fiber foods. You
Mm.
say to people, what fiber are you having? I have spinach, not really having that much fiber if
Yep.
your dinner is white rice, meat, and a little bit of spinach. Like we need to elaborate on this. You're never going to get to 25 grams just with
No.
that.
And I
Yeah.
love that because especially with that gut kind of diversity picture that we're talking about, it's actually something that you would think, oh, I'm super diverse, but we're all creatures of habit. We all pick for
Yeah.
the same foods. We all, go to those same recipes that we're creating. And we just kind of eventually, if you take stock of your diet, you might actually find that you're not introducing too much. But also,
Yeah.
I think that idea of I guess people think all vegetables are fiber, which they are, but like there is a difference between, like Yazzie said, a spinach leaf or a chickpea or a
Yeah.
broccoli and because like those low and high FODMAP prebiotics that we
Yeah.
find in our food, they can make a difference. And, we don't even want to go into, well, I can't tolerate those. And that's why you see a practitioner to figure out why that's the
Yeah.
case. But you're totally right about, that diversification and that high fiber diet,
Mm.
how it can change your microbiome and has all of these other systemic effects, including management of PCOS. So,
Yeah.
you know,
Yeah.
the connections are there. Are there any other things that you see? Like, does beta glucuronidase come up? Do you see, what are some other markers or correlations and trends that you're finding with a PCOS patient?
Beta glucuronidase certainly can be an issue, and obviously, as we know very well, much more likely to be present with a dysbiotic picture and with a constipation picture. But it's not as much of an
Mm,
issue in
cool.
PCOS generally as it is, of course, in endo, where
Yep.
it's a really common contributor and something that we need to look into as one of those hormonal differentiations that has absolutely nothing to do with the phenotype
Hmm.
in our patients. We'll be looking at their estrogen levels, even with or without ovulation, and there is a bit of a tendency for a high and a low estrogen PCOS type. Very,
Yep.
very, very different types, very different ovarian activity. But of course, also with that, we can have different detoxification tendencies. And of course, if we're looking at the higher estrogen PCOS type, then we're definitely considering that beta glucuronidase may be contributing to that estrogen recycling and poor detoxification.
Yep, yep. So again,
Mm.
individual, as we're always coming
Yeah,
back to that one. Don't forget it,
yeah.
people. So,
It's sad that it's not cheap, but
mm,
a good gut test is obviously one of the most powerful clinical tools that we can offer our patients, isn't it? That
it is.
individualized treatment is
Yeah.
phenomenal.
And like the one that I use, I love Cobiome's
Yeah,
test, and that one is
obviously.
just
Yeah,
amazing.
yeah,
And I prepare people for the cost,
yeah.
which can range depending on, about 350 to, 480 or something like that. So
Mm,
again, it's not small, but I always, I guess, try to remember and convey it's like in a way, this is cost saving because
exactly.
it saves time, energy, money on strategies
Yeah,
that aren't working. Now,
yeah,
I know it's easy to say this will actually save you money as you give them the
yeah,
bill, but like
yeah,
if you think about it, how many supplements or different
yeah,
things would you be trying that would eventually end up being around the cost of the test that
yeah,
haven't actually got you any further? So there's just a
yeah,
transfer of cost. That's how I
yeah.
like to see that.
Yeah.
Yeah.
And
So
ultimately, my goal is that you don't have to see me that often.
yeah, we want to say goodbye.
Yeah, exactly. I want you to feel well so you don't feel like you have to see me.
Yeah.
And if I just use my best educated guess on your gut,
Yeah.
as educated as it is, it's especially with gut work an absolute guess. And so we could hit the nail on the head, but
Yeah.
we could get it we could get it wrong and continue to get it wrong, and we could be working on it for 6 or 12 months. Whereas with this investment, not only in the long run will you save money with supplements, but
Mm.
you'll also save money seeing me.
Yeah.
Even if we get along, we don't want to sit here. You don't want to pay me to talk to you for 30 minutes, every month, as
Yeah. I
little as
mean,
possible.
you're lovely, but that's so
Yeah,
true. Yeah.
exactly.
So now I guess into this testing space. So we've spoken about,
Mm,
that potentially for some people a gut test might be important, but in terms of that testing and diagnosis, because we want, I guess, accuracy in our diagnosis. We don't want to have a
yeah.
misdiagnosis. What tests or how do we do this? So what is it to get a PCOS diagnosis?
Yeah, so medically, the guidelines were changed in 2023 so that gratefully an ultrasound isn't necessary anymore.
Mhm.
Ultrasounds, of course, intravaginal ultrasounds are
Not fun.
invasive.
Yeah. Yep.
And there are lots of reasons why some people wouldn't want to have them,
Yep.
why many people wouldn't want to have them. So
Hmm.
now we're able to use anti-Müllerian hormone as a surrogate marker for an ultrasound. And then the diagnostic criteria are actually not very complex medically. So it's an AMH or an ultrasound, and then it's either the presence of hyperandrogen symptoms.
Mhm.
So it can just be acne and hair growth. Doesn't even have to be proven on a blood test, but it's symptoms and or
Yep.
pathology.
Yep.
And then oligomenorrhea is a diagnostic criteria as well. And then the insulin resistant markers, but they're very basic
Yep.
medically, in that they really tend to just look at a fasting glucose and a HbA1c. But we know, not just clinically, because we've been doing it forever, but also in the research, that it's much more likely before PCOS becomes an established metabolic condition, if it's
Mm.
going to, that actually the sign on paper that's more important to test is insulin rather than
Yep.
glucose and HbA1c. We'll do all of them,
Yep.
but if you're only doing a glucose and or a HbA1c, you'll often miss a high fasting insulin.
It's like, I guess the step before it starts getting shown up there.
Exactly.
And I think,
Yeah.
maybe that's also good for people to remember if they're talking to their GPs about that, there may not be, I guess, the forthcomingness with that, whether that is a personal preference, a Medicare issue, but there is private testing options if you're wanting to
Yeah.
know that, which is sometimes what we're having to do as naturopathic clinicians that don't work under Medicare. We
Yeah.
ask our patients, to privately pay for these to get that information.
Yeah, absolutely. And it's so fair for GPs because they are under
Absolutely.
very, very, very strict guidelines.
Yep.
Yeah, and that's a totally different conversation
Hmm.
about what the government is willing to invest in
Yep.
preventative health care,
Yep.
but it's not necessarily a reflection of what the research
Yeah.
shows us is best clinical practice,
Yeah.
but it is what they're bound by.
For sure.
And so, we're actually really lucky to be
Yeah.
able to access those tests, and B, to be flexible to
Mm.
work in a non-restricted model, so we can offer
Yeah.
those people that want further support that support quite easily. We can organise it very easily.
Yeah, and like that's what we're talking about team care is that there may be majority of the tests that are, Medicare approved through your
Yeah,
GP, and there may only be a couple that you need to kind of follow up on. So once
yeah,
again, team care is a fantastic model if you've got a good team that you're working with.
exactly.
And like you said, I guess the interpretation of those, especially when we're talking about insulin, you may fall still within what is given as the reference range, but there still be, I guess, a hyper insulin type picture there. So
Yeah,
again, interpretation of these is the
yeah,
next step to actually even having those results.
yeah. And if you don't mind me adding around reference ranges, like
Definitely.
they're so deeply confusing, I think, for
Mm,
people that don't really understand how they work. Most people assume
yep.
that they're based on what has been shown to be the optimal range, but actually they're predominantly just the reflection of the average of the cohort attending that particular pathology lab. So
Mm,
also even different pathology labs will have different reference ranges. And of course, the cohort attending that pathology lab may be far more likely to have a disease state than an optimal state.
yeah.
So I'm sure, like you, I'm not even vaguely looking at reference ranges when I'm looking at pathology
Yeah.
results. I'm looking at patterns in the individual's results, and I'm looking at what I know to be ideal rather than just not diagnosable as diabetes.
Yes. Yeah. That is important. I'm glad you said it. So,
Yeah.
once someone has a diagnosis, we was kind of started speaking about this, particularly in relation to the gut, but in terms of what to eat when you have PCOS. And again, individualization, it's the umbrella for
Mm.
everything that we're talking about. But what are some myths that you're really wanting for people to dispel.
Mm.
What is the science saying about, I guess, PCOS optimal type diets?
Mm. Uh, Probably disappointing to everyone is that the science says not much at all.
Oh, good, great.
Yes, nutrition
Mm,
diet studies are, of course, notoriously difficult to conduct because A, there's no placebo blinded group,
yes.
and B, you try and tell anyone to only eat a certain thing for 4, 8, 12, 16 weeks. You're going to have very poor adherence. And how do you even confirm that those reporting have
Yeah.
adhered to it? So it's all self-reported. The quality of that sort of research is never considered to be high. Then on top of that, there's just not a lot of motivation for those studies to even take place, of course, because it's not leading to the development of an
Yes.
expensive drug, blah blah blah. But yeah, so the only consensus that's been reached is that the Mediterranean diet helps. The Mediterranean diet is
Hmm.
kind of just the conventional go-to for healthy diet. It's the diet that they've decided is the one that they'll test with everything.
Yep.
But obviously, what that encompasses is whole food, high fiber, plant and animal proteins, a good portion of those animal proteins coming from seafood, and good antioxidant and polyphenol intakes from a wide variety of vegetables, and of course from olive oil in the
Yep.
Mediterranean diet. But if you're going to elaborate on that, of course, a traditional Japanese diet also offers very similar benefits, but with slightly different foods. So a whole food diet generally, as I said before, around carbohydrates, different tolerances. I do not like to strictly cut them out at
Yep.
all, but depending on the individual circumstances and what we're trying to achieve and the time frame we're trying to achieve it in, I will give some guidelines for those that are able to count macros, etc. I'm happy to,
Yep.
I do give those guidelines for those for whom that's too restrictive or
Yep.
too triggering. Obviously, we don't go there at
Yes.
all.
Yep.
A good general piece of accessible advice for everyone, though, is the glucose goddess on
Oh yeah.
Instagram that I'm
Love
sure
her.
you've heard of.
Yeah. Yeah.
She's written a great book called Glucose Revolution. Very, very science-based
Mm,
book, but it's a very inclusive way of eating. It's not
mm.
about cutting out any food groups, but she gives lots of dietary and lifestyle tips around how to eat in a way that has a lesser impact on your blood glucose. So very relevant for most of our PCOS
Yeah.
patients, but also relevant for just about everybody, and certainly anyone with any metabolic or inflammatory disease state.
Look, and honestly, that's probably the majority of us these days, given, I guess, the standard and of our what I guess we have accessible for us in terms of food, even though we've got fruits and vegetables accessible, we've also got chips and fast food accessible to us.
Yeah,
So
yeah.
these strategies, and I also love it how while there's individualization in that you do go back to the basics of like that Mediterranean style diet. It is, in a sense, boring, that it is just your
Mm.
whole foods, it's your anti-inflammatory foods. We've had other people talk about the Mediterranean diet in relation to digestive conditions, the
Mm.
microbiome. So, like, I almost get excited when someone says something really basic and boring, and that we're not about to talk to people about convoluted fasting and juicing and like,
Yeah,
really
yeah.
crazy strategies, that it comes back to basics. Because I think the noise online can have you thinking that
Mm.
you're about to jump through a ton of hoops to have a diet that is
Yeah,
suitable. And
yeah,
stripping it back to these things, I think again just gives a sense of this lifestyle can be sustainable and it makes
yeah,
sense.
yeah.
So I love that you kind of mentioned the boring Mediterranean diet.
Yeah, 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 good. And it has to be like has to be livable, right? You have to be
Yeah,
able to go out to dinner with your friends. It
yeah,
can't isolate you.
yeah.
And obviously, I mean, maybe not obviously, but my absolute biggest bugbear about our profession, if I'm allowed to say one, is
You
the
can.
encouragement of food restriction,
Oh
which
yeah.
of course very easily
Mm,
triggers disordered eating or eating disorders for many people, I was going to say for those who are vulnerable, but that's
Yeah.
many
Yeah.
of our patients, especially women and AFABs.
Mm.
But also, yeah, just making rules that are unnecessary. Like, I
Yeah.
don't tell people to stop eating any food group unless it really is an issue, unless it's really worthwhile and they'll
Yeah.
get the benefit out of it. And then we talk about how they can practically do that and the things that we can use to replace it.
Yeah.
But yeah, there's in my book, there's no such thing as no one should eat gluten, no one should eat dairy, blah,
Yeah.
blah, blah.
And I
Yeah,
think, just to kind of jump on that, I think even our approach to gluten, there is definitely people who benefit not being on gluten, but it's not
totally.
everybody. And I know
Yep.
Brad Leach is on
Yeah.
a rampage at the moment with
Bring back brains.
yeah.
Bless.
His love for everything gut and food is just
Yeah.
it's the breath of fresh air that we need. But it's actually when you start looking at all the benefits of gluten containing grains, and we're not talking about the white bread, we're talking about, beautiful rye. He loves his rye.
Love my rye bread too.
It's
So
delicious.
good.
But
Yeah.
there is a place for many people to have these lovely gluten-containing grains. So gluten isn't
Yeah.
evil. And again, like
Yeah.
we're trying to get people to not think it has to be a cardboard diet to have any results. So I love that
Yeah.
change, and I think there is a conversational change that is happening. There might still be a few people that are still like, no, 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 no. But I think there's a lot of people
Mm.
that are having a bit more of an inclusive mindset in our field as well. So
Yeah.
I
Yeah.
love that change.
Yeah, I think so. I think that, yeah, we're less likely to do that now than we might have been in the past, but
Definitely.
it was worrying.
Yeah, no, definitely. I even know that
Yeah.
my practice, even from a perspective of people with bloating and things like that,
Mm.
are more
Mm.
inclined to actually probably use more digestive aids as,
Yeah.
more so than
Use some enzymes where you get on top of the problem.
exactly. And like,
Mm.
but again, each person is really individual,
Yeah.
so we just kind of take it as
Yeah.
it comes. Can we please talk about some herbal, nutritional, and again, not prescribing at all here, so
Hmm.
no one
Hmm.
run to the shelf and get some stuff, but
Hmm.
what are some really wonderful things that we're using in the management and the treatment of PCOS?
Yeah, so inositol would be the most well known. It's
Hmm.
even made its way into the guidelines from the conventional guidelines
Yeah.
from 2023. So usually we're just using myo-inositol. The decaro-inositol can actually be androgen promoting at the
Oh,
ovary, especially in higher doses. It's not really even available in Australia through the TGA anyway, so we don't really have to access it or worry about it here. But if you are using it, it needs to be just in a 1 to 40 ratio with the myo-inositol.
yep.
But we get the benefits that we need anyway out of the myo-inositol. What I would say about inositol in general though, is that from my perspective, the guidelines, the dose is too low. Like, I prefer to start at a good 6 grams a day.
Mm.
Often I'll go up to 12 grams a day, which is a lot of
Yep.
inositol, but that's where we really see the traction. It is, speaking of gut though, very poorly tolerated for anyone with FODMAPs intolerances or SIBO. So, we do need to be cautious of that and address any gut intolerances. It's not that you're allergic to inositol, so
Yep.
there's a gut issue.
Yep.
So yeah, often that will need to be addressed first.
Hmm.
And then we have lots of supplements that help generally with our capacity for glucose metabolism. So magnesium and zinc and B vitamins are just key run-of-the-mill everyday ones.
Yep.
And not necessarily saying that supplementing them will improve your glucose metabolism, but if you're deficient
Yeah.
in them, you're more likely to have issues with glucose metabolism.
Yep.
And then some less common known nutrients like lipoic acid and chromium, of course, are key again for carbohydrate metabolism and insulin sensitivity. Chromium specifically also for pancreas function.
Yep.
From a herbal perspective, we've got some great metabolic herbs like cinnamon, gymnema, fenugreek that all help to improve our insulin sensitivity. One that is neither, and is actually a food, of course, is acetic acid in vinegar. So vinegar is a great addition to anyone's diet, but especially those for PCOS.
Which makes sense if you follow the glucose goddess.
Exactly. Yeah, it's one of her key hacks. But it's so great because it really, the way that it works in particular is it increases your muscle uptake of glucose.
Mm-hmm.
So I'll often say to my patients, it's a little bit like, and I'm not saying you shouldn't do this, but it's a little bit like hacking exercise.
Yeah.
So of course, after exercise, your muscles are so much more are glucose hungry. After vinegar, your muscles are glucose hungry.
Yeah.
So her key tip is to have apple cider vinegar in water before eating. Got to protect your teeth, of course, with a straw.
Yep.
But a really good way to do it to also get the fibre in is to just have a vinegar dressed, and it doesn't have to be apple cider, any vinegar except for sugary vinegars like balsamic, but any vinegar dressed and olive oil for the antioxidants, dressed salad before your meal. You don't have anything after it, but it's such an easy appetizer. And if that is even just like snacking on carrots or, cut up vegetables with that either on the side or as a drink while you're preparing food, that itself can make a significant difference to your blood glucose, both because of the acetic acid, but also, of course, just because of the fibre. And as she speaks about a lot, putting the fibre in your gut before you eat slows the absorption of the carbohydrates and gives you less of a glucose spike after eating. But then other herbs, we use different herbs, obviously, for hormonal things. Penny and licorice combination would be the most famous. It's a really centuries-old Chinese formula that we have happily adopted. But it's very specific for a high testosterone, low estrogen picture because it really works to induce aromatase. It's also a bit of an androgen, an anti-androgen action to it in other ways, but its key function is to induce aromatase. So it's for that specific type. We'll use different things for the gonadotrophin imbalance depending on what we're seeing there. We'll use a lot of curcumin if we're seeing inflammation as a contributor. There are herbs like berberine which are well researched around PCOS, but as we know very well, has the potential to have a really negative impact on the gut microbiome. So I very rarely use it. And when I do, it's for very specific reasons, for very specific periods of time.
And I'm so glad you mentioned that because there's a particular popular brand at the moment which is, really promoting berberine for glucose metabolism. And unfortunately, again, it's just it's zoned in on what it can do. Yes, it can help blood glucose regulation, but there's not that holistic picture, which, back in a really early episode with Dr. Brad, he spoke to, again, the misuse of berberine and how it can actually affect the microbiome. So given that you've just mentioned a ton of other blood glucose regulating strategies, let's kind of lean on those first. And
absolutely.
Again, like even if you see berberine as a blood glucose support on the shelf, please be wary of that. More harm than more good. We don't want that to happen. But
it's pretty wild.
I wanted to ask you also, so one other herb which gets a lot of like, take this if you don't have a period or you want to regulate your period.
Oh, I know what you're going to say.
I know you do. Vitex, our beautiful chaste tree. Please, we need to caution people about the use of Vitex.
So first thing to say is I love Vitex. I'm a champion of Vitex. Probably one of the things I'm best known for as far as my practitioner education goes is the work that I've done around educating practitioners around the mechanism of action of Vitex, how it actually works. And it's a profoundly effective herb for some presentations. But because it's so effective and honestly, unlike a lot of our other herbs, it has a very distinct mechanism of action. It also has side effects. There are two types of drugs, ones that work and ones that don't work, and ones that have side effects. And this is one that works and so it has side effects.
Yep.
And that is not a problem if you're taking it and it's meant for you. But in cases where it is contraindicated, it can do all of the wrong things. And the two key areas where it can be problematic in PCOS is it can contribute to ovarian androgen production, so increases testosterone levels, and it can contribute to gonadotrophin disturbance, so it can contribute to then more anovulatory cycles. So often people might take it and see one good cycle and then all of a sudden not have, not have a period for 100 days. So it really is, from my perspective, it should be prescription only.
Yeah, look, and I did I did your training around Vitex, and I knew that particularly in that PCOS picture, it wasn't the magical herb for everybody that, I guess it is on a pedestal in so many ways, but it needs to be totally cautioned in terms of how we use it. But again, there was an understanding of how incredibly wonderful and complex this herb is. Really, you did have to find the patient for it. It wasn't applying the herb to the person. It was really making sure that they were a match. Otherwise, like you said, you're going to have literally the opposite of what you're hoping for and a worsening of symptoms. So again, anyone who's reaching for the Vitex that isn't sure that it's right for you, speak to someone that knows how to understand if it's right for you, because we don't want you creating more problems than what you may already be experiencing.
Yeah, absolutely. And as a general rule, if you haven't seen anyone, just don't use it if you've got PCOS, and don't use it if you've got endo.
Yep, great. There you go. Yep. You heard it from the best. So I've got two last questions that I'd love to end on. It is, if someone knows or suspects they have PCOS, what is one thing that they can start today? And then I guess the last question is your number one piece of advice for anyone out there navigating or struggling with PCOS. So what's a today thing, and an overall, your number one tip?
Yeah. So what I would say is exercise is really helpful for basically all PCOS presentations, but with the emphasis that the type of exercise that works for an individual really varies.
Yeah.
It's true that, of course, for most women and AFABs, resistance training is underutilized and really useful. And cardio can be helpful or problematic for PCOS. It depends on obviously how adrenal and stressed you are and how much the concern cortisol is, and we don't want to be working for weight loss with all of our patients. So certainly getting into a routine with exercise that is right for you and also addresses stress management, because stress is often a big part of the picture, often as a driver, but also, of course, as a consequence of PCOS. And then, if I can go for two, let's just say fiber from a dietary perspective, more than anything, let's just say fiber. In the long run, I think that there's two considerations. I'm not opposed to the pill. If I was 22 and had acne and irregular cycles and was putting on weight, and I went and saw a naturopath and they told me to do all the things that I would have to do to turn that around, and then I went and saw a doctor and they told me to take one pill a day, I would probably at that age have done that. And that is completely fine. It's not necessarily without consequence, but in my experience clinically, those consequences can be addressed. And, it doesn't hurt, of course, to get good functional medicine support at that time, but probably a lot of people are not financial or engaged enough in their health in their 20s to do that. And that's totally fine. That is what it is. When it comes to coming off that pill, whether it's for symptoms, health, or fertility, then I certainly encourage that they engage somebody who can help them navigate that window, because it probably will come back to be a problem. Not always, but it probably will. But outside of that, if that's not the approach that you want to take, then, I am biased, but I really do think that our holistic approach, which also involves appropriate referrals
Yep.
to the right practitioner of every other expertise. I think that we are just really uniquely positioned, not just for PCOS, but for all in my area, at least reproductive health conditions or presentations, because we are able to work with all of those other practitioners. And I just think functional medicine is, I just think it's the best form that there is, taking the best of each world and bring it into your practice, not being afraid of referrals, not being afraid of collaboration, but also understanding that humans are complex, and having that skill set to assess the multitude of factors that might be influencing that individual really gives us an incredible capacity to support patients in really profound ways, to be honest. I've been doing this for 20 years, and I'm more convinced than I've ever been that the impact that we can have on people's lives is it's unique.
It's profound.
We're lucky.
Oh, look, I think you gave so many in terms of the today and the ongoing, and I guess your biggest take home
way
tips.
Too many.
No, I think we all wanted that little bonus. I mean, I say one in case people are struggling for that, but you're like, can I have more? Absolutely. There's no listener that's just saying, I just want to listen to one piece of advice. Give me more. But they were, again, I love it because the stuff that we're talking about is fiber, and we're talking about finding an appropriate exercise regime. Also, even mentioning about, the pill, I guess there is still that sense of, look, it might be okay, but just, for whatever place and time that you're in, but being aware that when you come off, this is maybe the type of support that you want to get. And like we kind of touched on earlier before, particularly if there's that fertility and wanting to start a family, that's, I guess, in that near future goal, to be thinking about that and giving yourself a period of time to kind of work through that. Because as we know, there's a time crunch feeling when it comes to the fertility journey. So just give yourself a bit of time and hook up with the team at RH Health, Rhiannon Hardingham's clinic, which they all do amazing things. So I guess on that note, if people want to work with you, learn from you, I know that you're just saying that you're chockers with your clinic, but here have some more. How do people connect with you? And we'll put it in the show notes.
Fabulous, thank you. So our online platform is RH Reproductive Health. We have 4 naturopaths. I'm one of them. I don't take new patients, but our other 3 practitioners, Sage, obviously, who you've interviewed, and lovely. Raoul and Josephine, are all highly experienced and have all of them have worked with me since the start of their careers. So I've mentored them the whole way through, and I couldn't recommend any of them
they're incredible.
more highly. They're really great. We have a great little team. And then the practitioner education is what I really do most of my time and effort in these days, other than all of the long-term patients that I see that will always be there. So clinic will always be busy. But the practitioner education, where we do education on everything fertility and hormone related, from IVF to PCOS. Tomorrow we're running a webinar just on adult acne, migraines, PMDD, the whole gamut.
You've got a Vitex
webinar, just Chase Tree.
Look, there's plenty for people to explore if they're wanting to get involved. And like you said, even though if you're not taking on patients, your team is incredible, as if they wouldn't be working so closely to you. But in their own right, they're fantastic.
I'm very lucky.
So thank you so much, Rhi, for coming on and sharing everything that you know. It's been amazing. I think we touched on some wonderfully controversial topics, which I think we feel a bit more clearer and comfortable on, and also just giving people a sense of, I guess, empowerment, and that there's some really simple strategies that they can start on today. So you're an absolute dream to have spoken to today. Thank you so much.
Pleasure. Thanks so much, Rachel. Thanks for having me.
Thanks for tuning into Gutsy Talks. I hope today's episode left you feeling inspired to take the next step in your gut health journey. If you're ready to dive deeper, head over to rachellarson.com.au. There's a range of courses and resources waiting for you. If you loved this episode, I'd be so grateful if you shared it with others who might benefit from this information. And so you don't miss out on future Gutsy Talks, be sure to hit follow and leave a review. I'd love to hear your feedback. I'm Rachel Larson, and I can't wait to connect with you again for our next Gutsy Talk.